Welcome everyone that's joining. We're going to jump right in, even if the numbers continue to climb up a little bit for who's here, because there's a lot to cover today. So I apologize for that up front because I already am a fast talker and today is probably going to be just as fast as always. If it's too crazy speedy, just comment in the bottom. So like Karan had mentioned, it's improving access to substance use treatment and community withdrawal management services, or WMS. If I say that, it's just withdrawal management services today. And we're really going to highlight Medify's withdrawal management recommendations and manual. Wonderful. My disclosures. So I do have speaking honoraria that I received with both Indivior and Master Clinician in the past, and I am an employee of Women's College Hospital working with Medify. To mitigate potential bias, I will try to use both brand and generic names whenever possible. I'll highlight any off-label use because there's quite a bit that happens in addiction medicine at this point. And please, bring up questions if there are any about any real or apparent conflicts of interest. I'm happy to hear them. Okay, so what we're going to do today is go over where withdrawal managements began, where they really got started, where we are now in the system. Then we're going to go over the recommendations and the manual kind of squished together. There are going to be key messages for each of the different substance use disorders that we're going to talk about today in substance use. And there will be case studies for the different topics as well. If we don't get through all of them, I apologize, but we're going to try to get through as many as possible. So opioids, alcohol, stimulants, benzos, and cannabis and nicotine if we have time. But that sounds like a lot, so we'll just dive in. And then, of course, at the end, we'll go over next steps and future goals. To start with a poll question, if we can throw that up. So do you see withdrawal management or detox as a component of the addiction care pathway? Really, in the end, withdrawal management should be an essential component of the addiction care pathway, even though they may not always have been. Hopefully, that's the direction that we're heading in now. So if you thought no, that's okay, and we're going to go over the reasons why no. And if you thought yes, then you're ahead of the curve, and that's wonderful. Withdrawal managements do provide an immediate and low barrier access to treatment and services, which is why it's so important that they be roped into the addiction care pathway along with the emergency department and RAM clinics and outpatient addictions clinics and safe injection sites and everywhere else that addictions care does happen. So where we began. So withdrawal managements really started as a response to public intoxication or chronic drunkenness offenders, as they were called. So police could really only bring intoxicated people that they would find to the hospitals or to the jails. And neither of those locations, obviously, are very sympathetic. There can be a lot of stigma, and they don't want to house intoxicated people. They have other purposes as well. But the Public Drunkenness Act of the 1960s did allow police to send intoxicated people to a withdrawal management rather than a jail. This meant a non-clinical but compassionate and safe place for intoxicated people to stay, as opposed to the hospitals, which we know aren't always that accepting of someone in that condition. Unfortunately, this also meant that many withdrawal managements were exactly what we used to call them, beds and buckets. And that's all that people got there. They had a bed, they had a bucket in case they were sick, and that was really the extent of the care. So they were an honest dumping zone. So if you said no to that question, then I can definitely see why, because that really is how withdrawal started. Luckily, over time, that started to change. Many detox actually became hospital sponsored. That was great news. It actually came out of legal necessity again because there were concerns with police bringing anyone intoxicated not to the hospital for safety reasons. And so they said, well, if the hospital is sponsoring the withdrawal management, then the police can safely bring them there. So maybe a tricky way that it happened, but in the end, it's a positive because it did mean eventually more withdrawal management staff were available. There was more monitoring, eventually RNs, RPNs, and now even NPs that were starting to come on site. So more medical care was able to be provided in the withdrawal management. So for those that said they're not a component of the addiction care pathway, I get it, but really we do want them to become a part of the care pathway. Where we are now. So over the years, the withdrawal managements have received some funding, enough to employ withdrawal management staff, and eventually some sites were able to hire RPNs, RNs, and NPs. But when I say that, I mean they really did have maybe just enough funding for one NP for multiple sites or even an entire city, which we know is just not adequate. So the funding really wasn't enough. As you saw historically, they lacked medical capacity in these units to provide medication-assisted treatment for withdrawal and other acute substance-related conditions that presented, let alone all of the physical and mental health concerns that we know go along with these clients when they come into our care. It's not just that they need help with withdrawal or addictions. They have physical and mental health needs that have not been met before either. So this really created a large gap in care from the fully medicalized inpatient detox or withdrawal management services. So those are typically those in hospitals. They support complex and high-risk clients. They have full wraparound services. So they really get, hopefully, the best care possible while they're there. That created an inequitable gap and access to medication-based treatment when potentially you were just getting bed and bucket in the outpatient setting. This has resulted in preventable relapses and substance-related morbidity and mortality. We know that, for example, patients with opioid use disorder, if they come into a withdrawal management and they're not given access to opioid agonist therapy, many of them won't be able to or won't feel like they're able to stay. And they leave after they've been away from their opioid for a period of time, dropping their tolerance, putting them at much higher risk for overdose and death. Fortunately, not all negative, in 2020, 2021, there was some nurse-specific funding for withdrawal managements that became available. And that meant that LHINs were now able to hire some, like I said, RPNs, RNs, nurse practitioners, giving these units the medical capacity to treat withdrawal, to initiate things like OAT or opioid agonist therapy on site, and then hopefully to address more addictions care, more mental and physical health care as well. Continuing where we are now, where that really left us. Unfortunately, that meant organizations that had never had healthcare staff before were now hiring healthcare staff for the first time. There was a large gap in who they were going to hire, so a lot of new grads were hired to addictions, which is really a more specialized field. And it meant that clinicians that maybe weren't new grads, but hadn't worked in addictions before or worked in withdrawal before, including myself, were joining that field as well. And there really was a major lack of clarity on what should be offered and how to do it safely. So withdrawal treatment recommendations hopefully were, but they really were scattered over many different organizations, many different resources, and in some instances, like stimulants and cannabis, we know that they were just lacking altogether. So this is where the withdrawal management manual and recommendations really come into play. We're trying to fill that gap and make some resources that compress all of the different withdrawal management care, so you can grab and go, make your life easier if you are going into these settings, and honestly in many other settings as well. Advance. There we go. So the recommendations, we're going to start with those. So the purpose of these recommendations is to help WMS clinicians provide safe and effective medication-assisted treatment. So we know, hopefully you know, that AMHO, Addictions and Mental Health Ontario, have produced and revamped their withdrawal management standards. That's fantastic because they're high-level recommendations about how a withdrawal management should be run, and we needed those. But they are pretty specific, and so these recommendations came in really to target clinicians more specifically and medication-assisted treatments more specifically. So MAT or medication-assisted treatment are things like benzos for alcohol withdrawal, OAT or opioid agonist therapy, like I've said, for opioid withdrawal, anti-craving meds, those kind of situations. That's what the recommendations are really targeting more than anything else, because we know it's those treatments that have been shown to reduce morbidity and mortality. And the withdrawal does have a key role in initiating those therapies. The development of them, so just in case you're curious, they were written by a group of experienced addictions clinicians. They were produced with the support of Medify, and the strength of the evidence supporting each of the recommendations is outlined in the narrative below the recommendation. So if you're really curious about where does this recommendation come from, they do have a blurb on that underneath the recommendation itself with lots of great references. So if you are a curious person that wants to dive deeper, dive into those references there, because I think they're wonderful as well. So huge thanks while I'm doing this to the writers of the recommendations. On to the manual. So the manual is for providers working in residential community-based withdrawal management services to standardize care, improve documentation and information sharing, and provide quick access to relevant information. I'm missing one. Sorry guys, as I get my slides working. So they're really a collection of practical resources, a quick, easy access to information for providers, hopefully of all kinds. But when I say that, they are a first of their kind, and it's kind of novel that they were developed for and by nurse practitioners. And the reason I say that is because the funding that came out was really more for nurse practitioners. And so we found it very important that NPs be the developers of the manual that they were going to be using. That being said, we know and hope that the information included is universal. There are many different care providers that can use the information that's there. So the NPs reviewed substance use guidelines, best practice recommendations, relevant clinical research, and whatever existing withdrawal management policies they could get their hands on to develop these. But just as important as developing them were reviewing them. So they were reviewed by RNs, RPNs, social workers, counselors, withdrawal management staff, addictions physicians, emergency physicians, pharmacists, persons with lived experience. We really wanted them to be useful for those that were going to be using them and affected by them. So we made sure that the review was pretty extensive as well. Scope. So I do want to be clear when I'm talking about the manual anyways, that to be practical, we thought that the manual needed to have more of a focused lens. The more broad it was, the less specific it would be and the less practical it would be. So for the manual, we did focus on residential community-based withdrawal management, meaning in the community, but within a living situation. So they're not at home and they're not on the streets or in a shelter. And they're not hospitalized patients. This is happening in the community. We recognize that there's a huge gap there then, that community-based withdrawal support programs aren't specifically represented, although I think a lot of the information transfers well between them. Inpatient units aren't represented in the manual either. So there are some gaps that definitely need to be addressed. And this was just a starting phase. And because of the recent funding, we developed the manual with the assumption that all withdrawal managements in Ontario have, or soon will have, one NP and one RN or RPN at minimum. That may not be the case for all withdrawal managements yet, but we really hope that it will be soon. And if you're the opposite and you have way more staff than that available to your withdrawal management, we really hope that you go beyond the manual and not just limit yourself with what we've provided here. So huge thanks in going forward to the authors and the reviewers of the manual as well. Really quickly, these are just the components of the manual because we're not going to go through all of them. So if you look on Medify's website, you will find there's intake components, treatment recommendations, documents for the emergency department, discharge documents, sample policies, scales, so you can go and grab scales instead of Googling them, and a whole bunch of resources that are available as well. Okay, this is kind of the second component of the presentation today, hopefully a little bit more interactive. So the topics that we're going to go through are opioids, alcohol, benzos, stimulants, cannabis, and nicotine. So diving right in, we're going to start with opioids. These are the key takeaway messages from the recommendations really for opioid use disorder. So opioid agonist treatment, or OAT, has been shown to markedly reduce high-risk opioid use, overdose, death, ED visits, and hospitalizations, and improve quality of life. It is safe and feasible to start OAT in a withdrawal management setting. Patients with opioid use disorder who don't start OAT in WMS or who discontinue it while they're in that setting are at a higher risk for relapse and overdose death. Harm reduction interventions, so things like naloxone kits, should be provided along with OAT within the setting or upon discharge from that setting. So key recommendations there. So we're going to dive into a case study. I haven't made this one, hopefully you can interact still and use the chat box if you want to, but I haven't done a poll question for this one. So you're in a withdrawal management, whatever role you're playing, and you have a 34-year-old male presents having used 1 point of fentanyl smoked about 2 hours before he came in. He's been on methadone before, and he's pretty clear up front that he doesn't want to go back onto that. So how do you manage this patient? There's many options. If you want to put your option in the chat box, you can. But we're going to look first at the manual and the recommendations and kind of what they present. So the opioid agonist therapies from first, I guess, to third line are buprenorphine, second line methadone, and there's some question there. Buprenorphine is really first line because of safety purposes. So if you feel like your client is a high risk user who would have more benefit from methadone, it's not wrong to start them on methadone first if they were requesting it. we happen to know from our case already that the clients tried methadone and they didn't want to do it again, you definitely want to dig into why that is, because so many clients, maybe they weren't at an appropriate dose. They were never increased quick enough to feel comfortable on it. Maybe they had side effects and that's the reason they don't want to go back to it. Whatever those reasons are, you want to try to mitigate it with their future choice to make their life easier for them. Third line is SROM, or slow release oral morphine. I apologize if I jump into saying things like Kadian or Eslon during the presentation. I mean morphine. So you do want to allow and encourage patients to continue their opioid agonist therapy if they're on it. This person isn't on any, so you do want to assess them as soon as possible when they come in, and you do want to start your opioid agonist therapy as soon as possible. Okay, this is it seems pretty crowded on here. Hopefully it's not when you look at it, but it really is an algorithm for opioid use disorder treatments. And it's one of the reasons that we say that this is a universal document, because although we developed this for the withdrawal management, this is going to work in any treatment setting. So it goes over how to do a basic start for buprenorphine, methadone, and SROM, start to finish pretty much, which is nice. And then all of the little considerations that you would need on the second page. So that's included there. They're really the basics. And if you do want to go more in depth, of course, you can go beyond this algorithm. So for our 34-year-old male, we present his options. We let him know all of the options that are there for him. And whichever he chooses, you just follow that algorithm. So if we're following the buprenorphine algorithm, seeing as he doesn't want methadone again, and we've dug into the reason why, and it's not an option right now, you talk to him about bup, and he agrees it's a good idea. But he is not in the time frame from last use, because he just used a couple hours before he came in. He's not in the time frame to get started, but you really don't want him to be uncomfortable during his stay, and you don't want to miss him if he's going to leave early. So you do want to make sure you're starting your opioid agonist therapy as soon as possible. So for this gentleman, if you're following this algorithm, you can put it in the chat if you want to, because there's many, many options available. But what you would be doing is offering symptomatic support in the meantime and a microdosing. The fun part about withdrawal management being in a residential setting is that and this is not every setting out there, but if you are lucky enough to be in one of these settings, you have some confidence of saying that illicit opioid use or other opioid use isn't ongoing while you're doing the microdosing. That means it can be a very short-lived microdose, usually just a couple of days, enough to get them into the time frame appropriate from last use to start buprenorphine. So you might do 0.5, 0.2, 0.5 twice daily the next day, 1 milligram 2 or 3 times the next day, and then you're going to jump right into a standard start after that, because this client does not need to be microdosed for 1 to 2 weeks in any means. As soon as they're in the time frame from last use, you jump them onto buprenorphine at a comfortable dose for them. And do not forget to use your symptomatic support throughout, because that will be very important to keeping them there. So many people are talking about macrodosing right now, and Medify is they're developing some recommendations for that as we speak, which is pretty exciting. But when this manual was developed, it was last year, and that wasn't up and coming enough yet to really include it in the recommendations, not enough evidence. So it is something that's more in the works. We do have a macrodosing recommendation in the manual, but it's really just for the treatment of precipitated withdrawal, which has kind of always been an option. If someone does end up in precipitated, one of the options is to just continue to give them high dose buprenorphine until you've powered through that PW and made them actually feel better instead of worse. So there's your options for our upfront opioid use disorder. And those are just some options. If you have a different way that you would want to go about it, there's many. Okay, next up for this client is not forgetting the rest of it. So you have them on buprenorphine. You want to make sure you have a continuity of care. So ensure follow-up is arranged for this patient. It's not just start the prescription and you're done with them. They have to know what clinic they're going to, specifically the hours of the clinic, provide them with the phone number and a specific appointment if you can, and at least a week's worth prescription ongoing. So they've bought themselves some time to get to that clinic. You don't want to leave them having to go to that clinic the exact day that they get out of your detox. They have a lot of other things that they need to get organized, like housing and money and food and safety. So don't make them struggle. If you can help it, provide them with a little bit of an extension prescription. Kind of coming back to the same case study, but slightly different, just because there's so many different ways that someone in opioid use disorder could be treated, or opioid withdrawal. So same thing, you have a 34-year-old male who presents after having just used fentanyl. You meet and review the OAT risks and benefits. He's been on methadone before and again, doesn't want it. He declines buprenorphine. He knows he can do it on his own and he just needs to be off of the streets for a bit. If you work in a withdrawal management, you know this is a very common presentation. People do need breaks from their use and they do need safe places to stay. So what are you going to do for this client? You're going to present information. And I just want to be clear, although I have quotes on and statistics and that kind of thing on this page, you're going to be a human when you present it to the patient. You're going to personalize it as much as possible. Let them know that you're telling them this information because you care about them and you don't want, you want to see them do well and be safe and be comfortable. But there is information that not being on an opioid agonist therapy when they discharge from withdrawal management does put them at more risk. So the first study, loss of tolerance and overdose mortality after inpatient opioid detoxification. So patients who successfully completed inpatient detox were more likely than other patients to have died within a year. That's a pretty impactful statement. Just one quote from the second study there, at 1 year follow-up, 4.5% had died. And in that third study, 91% reported a relapse, 59% reported that within a week of this inpatient facility. So these are pretty, jarring statistics, and you do want to keep them in mind when someone is saying that they don't want therapy. You do want to go through the risks and benefits with them so that they really understand it. In the manual, there are options if you're a clinician that likes to have this kind of stuff written down. There are samples that you can cut and paste into your EMR. They go over the risks of not being on opioid agonist therapy and an acknowledgement of loss of tolerance of opioids when you're going through withdrawal. You do not have to complete these forms. You can obviously just document yourself that you've gone through these risks and benefits. But if you like the forms, you can sign it, have your client sign it. You can put it in your EMR, which makes charting easy. And your patient can, of course, take it with them when they go because it does have information that they can reference back to if they want to. Next up for this client, you're not going to ignore them just because they don't want the treatments that you've recommended. You still want them to be comfortable as best possible and safe from complications. So symptomatic management is always going to be next up. Make sure you can offer them whatever you can. This is a tricky part when you are not a hospital-sponsored detox. It really is work to try to find ways to cover some of these treatments for your clients. And that's when you just have to advocate with your organization that these are important to keeping people comfortable and staying and getting them the help that they need. Next up, again, once you're done helping them feel better, you're not just going to ignore them and forget about them and move on to a client that said yes to treatment. There are so many other resources that you can provide to this client. So before they go or during their stay, you want to make sure they have a naloxone kit. They know where safe injection sites are if they've decided to continue using. They know about the National Overdose Response Service and how to use it. They know about walk-in services in their area. And if you're a comfortable provider, upon discharge, you can leave a prescription at the pharmacy for something like buprenorphine and give them a home instruction sheet. It's pretty easy to do, and it's a safe thing to give clients because we do home starts all the time. And it's an option telling them that just because they haven't chosen it now, they can always come back and they can always seek care in the future. It's not an always no. On the other side of the screen, whatever side of the screen it is for you, there's a list of all of the opioid resources that we've included, and there's lots more information that's good in there as well. This is just one of the scales we've included, the subjective opioid withdrawal scale, or SOWS. So that's an example of something you could give a client to go home with to instruct them how to start Suboxone on their own or buprenorphine on their own if they wanted to. Medify actually has in their ED toolkit a really great home start sheet as well that I use all the time to give to patients if I'm doing this, because it has really easy, I would say easier than the SOWS instructions for how to get started with buprenorphine safely. Okay, prescriptions. So, sorry guys, as I jump ahead. Prescription recommendations in the manual. Moderate therapeutic doses of a prescription opioid for chronic pain should be continued. There's no need to discontinue opioids when they're being used in a safe and appropriate manner. You do want to offer opioid agonist treatment for opioid use disorder if you suspect it. So if the patient is having major side effects from their opioids, that's one reason that you might want to consider it. Other tools to help you determine, because it's always easy to say but harder to actually know in front of you if someone is experiencing or suspect for opioid use disorder with their prescription opioids. So there's the concurrent or the current opioid misuse measure tool, opioid risk tool, pain medication questionnaire, screener and opioid assessment for patients with pain. All of those are available to you. They're all included in the recommendations in the evidence and in the references. So if you're wanting to jump to those, they're accessible there. But if you are just looking at a client, you just need to figure out their safety. So example, someone that comes in with 3 or 4 Percocet a day and they're doing well and using them appropriately, you might say no problem, they can continue them. Someone on 18 milligrams 4 times daily of hydromorphone cotton, you might want to do more of an assessment and make sure that they are using it appropriately, that it is effective for them, they're not having major side effects. Another major caution, of course, is if they're coming in for treatment that's requiring something sedating, like a benzodiazepine, you may need to drop their dose for just a little while they're being treated for a different substance use disorder. Complicates the picture a bit. Okay. Speaking of that, moving on to alcohol use disorder and alcohol withdrawal in a withdrawal management. So the major recommendations, in most cases, alcohol withdrawal can be safely managed in a withdrawal management. Honestly, in most cases, it can be safely managed at home, which is wonderful as well. Anti-craving medications such as naltrexone, acamprosate, and gabapentin should be offered to clients in the withdrawal management with alcohol use disorder. And there's a case, and this one does have a poll question. So be ready. You have a 56-year-old female client presents with alcohol use disorder to your clinic or to withdrawal management. Her last drink was 12 hours ago. A month ago, she tried to stop drinking on her own, but she ended up having a seizure and went into the hospital after that. So if you want to bring up the poll, please and thanks. It's just a true or false. Because it's been 12 hours from her last drink, this client is no longer at risk for seizures. True or false? Everyone so far has chosen false, which is correct. Just because it's been 12 hours from the last drink does not mean that they are safe from seizures at this point. Our highest risk for complications like seizures and DTs would be in the first 24, 48 to 72 hours. So those first couple of days after drinking, you really want to be more cautious. So even though it's been 12 hours, we're not in the clear yet. The most common time for symptoms of withdrawal to start to appear would be about 6 to 12 hours from the last drink. So you would expect her to be beginning to show symptoms of withdrawal, definitely at the 12-hour mark. So how are we going to manage this client in our withdrawal management? We actually, since it's been released, we've updated the alcohol use disorder and alcohol withdrawal algorithm. So if you accessed this algorithm when it was first released, you do need to go back to the website and get the updated version, because we tried to make it more reflective of catching those high-risk clients, which are a little bit more finicky to figure out. So you want to figure out, always the first question is, does this client require loading doses? So are they a patient that has had a history of complications? So have they had seizures, DTs, hallucinations, or hospitalization for severe withdrawal in the past? Those types of clients really need to be captured so we can do loading doses up front. This is going to make it a safe and effective stay for them wherever they're doing their withdrawal going forward. So our client, we know, did have a seizure just a month ago after they tried to stop drinking. So we're going to go ahead with loading doses for this patient. Loading doses typically means diazepam 20 milligrams every 1 hour for 3 hours, regardless of a CWA score. Of course, you're going to stop early if your patient is becoming sedated and their tremor is moving to minimal to no tremor at all. Then you're going to stop early. Otherwise, you're going to finish those 3 doses and you can monitor the CWA, but you're not going to dose based on the CWA throughout. So this is definitely what that client requires. Whether you're able to do that in your withdrawal management or not depends on what facility you're in, what kind of medical support you have available for constant monitoring, just to make sure that that client is safe, and how long you're going to be there afterwards, because you do want to have medical support available for about 1 to 2 hours at least after those doses have been provided. After that, you have options. So once the loading doses are complete, you can switch to symptom-triggered dosing afterwards, or a fixed dose schedule if you feel you need it. Symptom-triggered is always going to be the most appropriate way to go, but it really depends on staffing, because it does mean that you have to be continuously monitoring your client to see how their withdrawal is. You only dose your client if they're requiring dosing based on their scoring afterwards. That helps to minimize dosing because they only get dosing when it's appropriate. Otherwise, they don't get anything, and that's great. So if you have the staff and the ability to do that in your facility, fantastic. That's definitely the way to go. Many clients, most clients after their loading doses do not actually require ongoing dosing of benzos afterwards because they have that loading dose up front and diazepam is so long acting. But you can definitely have symptom triggered set up. I think it's a great idea to catch those clients that do have ongoing tremor or other symptoms after those dosing, that dosing has been completed. If your facility isn't spoiled and they don't have the ability to do symptom triggered yet, hopefully, then fixed dosing is the way to go. All fixed dosing means is that you're going to be dosing your client on a set schedule. So that's typically a 3 times daily, a 4 times daily kind of schedule. The client will be getting the dosing at those times. If you're not able to put PRN or as needed because your staff aren't able to make that judgment call, you do want to include hold the dose if sedation or drowsiness is occurring, because you do not want to be overdosing your patient with these benzos when really the dosing shouldn't be required at all after the loading dosing is done. At the bottom of the algorithm, hopefully you can see thiamine. We can't forget it. It's very important because it's so easy to prevent major complications. Dosing for thiamine varies across all evidence that you're going to look at. So we tried to capture as much evidence as we could and figure out what the most common recommendations are. So if you have IM or IV, definitely go for it. If you only have oral doses, use that. Don't neglect thiamine just because you can't do IM or IV on site. Not wanting to forget, this is not the patient for it because of her history of complications, but gabapentin definitely plays a major role for many, many clients that will only end up with mild to moderate withdrawal from alcohol. You can always use gabapentin as a benzodiazepine sparing option. And if you've used benzos up front for that higher risk client, once they're stabilized, you can convert to a gabapentin protocol afterwards. The beautiful thing about gabapentin, as we all know, is that it can be continued as an anti-craving medication ongoing. So that's kind of a nice one step to the other. Is there a way to get this information as a PDF? Yes, there is. It's all PDF available on the Medify website, which I'll grab the link for at some point and put in the chat box. But definitely, it's all PDF. This is just in the manual. These are the examples in case you haven't done fixed dosing taper schedules before. There are many, many ways to go about it. Here are some examples for diazepam, lorazepam, and for gabapentin, as well as for thiamine. These can be found in the alcohol withdrawal order set, which is PDF as well on the website. Thanks, Karan. You're awesome for getting that for me. The PDF link is in the chats if people need it. Last step for this client, but not least important, is anti-craving medication. You do want to be getting that client onto anti-craving medication before discharge, and same as with the opioid agonist therapies, giving them an extension prescription so that they can continue it and have time to follow up with whoever it is, their primary care doctor, their addiction specialist, their psychiatrist, whoever is going to keep that script going. The manual has a sample discharge document for primary care, just to make life easier for documentation. You could use this if you needed it. Pregnancy. So this is kind of going over both alcohol and opioids. Pregnant patients need to be given priority. So they need to be given access to the withdrawal management before anyone else on the wait list. Ongoing consultation with an addictions OB specialist is always recommended and should always be sought after when you do end up with a pregnant patient, no matter what their substance use concern. For opioid use disorder, offer OAT, any type of OAT as soon as possible, and arrange ongoing OB care. For alcohol use disorder, if that client is in withdrawal, send them to the emergency department. They do need to be stabilized in their withdrawal, and the best spot for monitoring for mom and baby is in the hospital. Until they're stabilized, afterwards, of course, with ongoing consultation, they can come back. If the client's coming in and they're not yet in withdrawal, you have to discuss withdrawal pros and cons, taper options, anti-craving medications, the benefits and risks. And if you're not the person that's comfortable with this, you need to get comfortable with it and develop a relationship with your local OB provider that works in addictions. Most cities have at least one person that you can think of, or a surrounding city has one person you can think of. And that's a fantastic relationship that you have to have. We can talk more about the pregnancy component. I didn't include too much here only for the sake of time. I say as I'm running out of time already, but we'll try to get benzos done at least. So overall recommendations for benzos. Patients on moderate therapeutic doses of prescription benzos for chronic pain, for chronic anything that's going on, may continue these medications well in a withdrawal management setting. The withdrawal management clinician may need to lower the benzo dose during their stay for safety reasons. And the withdrawal management may initiate an outpatient benzo taper if the dose may be causing the patient harm, or if the patient has a benzo use disorder, then that taper needs to be arranged as well. Okay, another case study. And I think this has a poll question too. So you have a 24-year-old male presents in moderate alcohol withdrawal 6 hours after his last drink, with prescribed clonazepam 2 milligrams twice daily, and reporting street Xanax use about 4 milligrams about 3 times a day for the last 4 months or so. So we'll throw up the poll question. So this client will require less treatment for their alcohol withdrawal because they're already on benzos. True or false? The answer, to go back to the poll, is false. They're not going to require less benzos because they're already on it. They actually have such a tolerance to benzos already, and they're already in alcohol withdrawal on top of the benzos they have been taking, that this client is going to require a significant amount of benzodiazepine to manage their alcohol withdrawal, which is going to flag concerns for safety in any outpatient setting. So in the manual, you will see that there is a list of resources for benzos as well as all of the other substances, and we've included a number of different benzo equivalent calculators. I like to use a couple for every calculation that I'm doing because they're all slightly different, and I do want to have, as accurate as possible, a range for dosing. So that's our first step for this client, is we really have to figure out an equivalent dose, or an approximate equivalent dose for their benzodiazepine. So they're on clonazepam 2 milligrams twice daily, about 4 milligrams, which is about 40 milligrams diazepam equivalent. For their Xanax or alprazolam, they're 4 milligrams about 3 times a day is what they're saying. So if we're going by that, it's 12 milligrams approximately they're using every day. So that's about 120 milligrams diazepam equivalent. So we're looking at about 160 milligram equivalents for this client. So that's something that they're taking on a daily basis. The good news for this client is that they're not in benzo withdrawal yet, because they told you they just used their medications and whatever illicit substance they had that morning before they came in. Benzo withdrawal takes a couple of days typically to set in, so that's the benefit. You do have a bit of time to catch it. The bad news is that they're already in moderate alcohol withdrawal after all of that benzo that they've already taken. So how are you going to manage them safely? So this isn't really a part of the benzo section in the manual, but we do have a pre-arrival screening tool as a recommendation. Obviously, go beyond this if you have the ability to at your withdrawal. But in here is included a combo of alcohol use disorder and benzo use disorder as a flag for needing clearance to your detox. And the reason for that is that the clients really will need high doses of benzos to manage their alcohol withdrawal and keep them out of risk most of the time. If you're on site, a healthcare provider is on site and they can provide that and monitor someone safely, then I think that could be considered on site. I think at this point, most withdrawal managements would say that this is a patient that needs to be stabilized in hospital before they are brought back to the withdrawal management, only because those doses are going to get pretty high. So when to transfer to the ED is another document, and you can see the benzo withdrawal recommendations right there. So thinking about managing we don't even know their alcohol withdrawal history, but since they're in moderate withdrawal at 6 hours post already, let's say that this is a person that we wanted to give benzo. So when we're thinking about the loading doses we did before, do we think that 20 milligrams, 40 milligrams, or 60 milligrams of diazepam are going to help this client be controlled enough that they don't have ongoing withdrawal symptoms and that they can stay safely? Probably not with what they've already had. And we honestly don't even know the answer for what specifically they've already had, because we know illicit substances are unfortunately all contaminated at this point. So again, another reason that higher monitoring would be a good idea for this client. But once they are stabilized at the hospital and they're brought back to you, there is a section in the manual for benzo use and how to manage it afterwards. So depending on what they got in the hospital, you have to figure out what dose this client is going to get for benzos for an ongoing taper afterwards. So there's some recommendations in here. Typically, the recommendation is to switch to one long-acting benzodiazepine. So you're going to take their diazepam equivalent and convert them, you don't have to go about it this way, but convert them to their that diazepam dose. You really do want to start, I really err on the side of caution and say start at about 50% of that total daily dose that they have told you they're taking when there is an illicit substance ongoing, because we don't know exactly the dose that they were taking. Benzo withdrawal does take a little bit of time to set in. They're in your residential facility, which is a bonus. So you do have the time to titrate or taper that dose depending on how they respond to it. You just want to get them to a comfortable dose before discharge, because at that point you can set up an outpatient long-term taper that's going to be much slower, and included in the documents are all the information about how to go about that taper. Cool. I think we have maybe time to go over stimulants. We'll fly through and stop if we have to. So overall recommendations for stimulants. Patients who report using crystal meth should be assessed for psychosis. Antipsychotic medications should be prescribed on site when indicated, and there should be clear criteria for transferring the psychotic patient to the emergency department. There is little evidence for medication treatments for stimulant use, but trials can definitely be offered. Okay, case study. I think this will be our last one for today, based on time probably. And there's a poll for it, I think. So a 38-year-old woman presents reporting daily smoked crystal meth use. During your exam, she is easily agitated. She's upset. She can't sleep at night. She has multiple verbal outbursts saying people are yelling at her. She reports not having slept, ate, or drank in 3 days. She does want to stop using everything, though, including her cigarettes. How are we going to manage this patient? So I like that we've included this level of agitation scale in the manual. It's maybe not as commonly heard because there's a bunch of monitoring for agitation scales. Unfortunately, almost all of them are hospital-based, and they include things like monitoring catheters and restraints, which aren't things most of us will have outpatient. This scale is much more simplistic. It really just looks at, is the client asleep? Are they awake? Are they agitated or irritable? Are they aggressive verbally? So if we're looking at this form, we can see that our client is probably a 4 because they are having some hallucinations, some auditory hallucinations that people are yelling at them. They are verbally aggressive and agitated, but they're not physically aggressive in any way. They haven't hurt themselves or anyone else. So knowing that they're a 4, next we're going to go to management of stimulant use documents and see what that means. So we've set it up so that you can kind of figure out what you're going to do with a level 1, 2, level 3 or 4, or level 5, or agitated psychosis afterwards. So our client is agitated. They are level 4. We are going to look to treat the agitation and drug-induced psychosis as well. And this is where you're going to want to stabilize them. One of my favorite options, just because it's safe, easy to use, and clients respond really well, is olanzapine, but you can see the other options that are there also. There's the option to add in benzodiazepines for that agitated client after your max dosing of your antipsychotic has been reached, if they haven't calmed, with the addendum of you have to be careful about monitoring. You have to have monitoring available for those patients because it's a lot of sedating medications. But after we've managed that, if the client does, they are able to calm down, you are able to keep them in the unit, they are able to sleep and eventually get some food and drink back into them, then you do want to eventually be talking to them about long-term treatment options, which, as we've already said, don't have a ton of evidence, but have some. So on the bottom of that page, you can see the long-term treatment options, and there's quite a few. So we'll do this last poll question then, is, oops, thank you. Which treatment options would you recommend to this patient? And there's quite a few options. I think you can only choose one. I'm sorry if you would have chosen more than one. I know that's a thing. But based off of this client who, while you're doing that, I'll just read the case again, is a 38-year-old woman. She reports daily crystal meth use. She's agitated, upset, can't sleep at night, multiple verbal outbursts, saying people are yelling at her. She reports not having slept, ate, or drank in 3 days, but she does want to stop use, including cigarettes. None of you are wrong. So if we're going back to our options, they could all be appropriate options, and you're always going to be looking at the case, the specific person's situation when they're coming in, because there's no fantastic evidence for any one specific treatment option. The only one that I would say may not be as appropriate for this patient, being a female, is topiramate because of the risk of pregnancy, but it's not like you can't caution them about that and have them on birth control before you're starting it. Disulfiram, agreed as well. This might not be the most appropriate case. Mirtazapine, you're definitely getting the sleeping benefit adding in, which is huge for many of these clients, as well as some weight gain. A lot of our clients that use chronic crystal meth would benefit for some weight gain. Naltrexone, we know that we have opioids mixed into our crystal meth specifically, but a lot of our stimulants. So with that caution on board, naltrexone could be good to block the opioid or mu receptor. That being said, it does mean that you have to have a lot more caution when starting a stimulant user on naltrexone, because you could have opioids on board and you don't want a precipitated withdrawal. It will really confuse the picture, upset the client, and you'll kind of have to start from point zero all over again. So if you are starting someone on naltrexone because you think it's their best bet after stimulants, do that urine drug screen, or if you can't do a urine drug screen, wait at least the 5 to 7 days before you're starting your naltrexone afterwards, after their last use. But it definitely can be great for blocking opioid use, for helping with previous opioid use disorder, and for stimulant use moving forward. Bupropion or Wellbutrin is a fantastic option. It probably would have been my option for this client, because of the smoking cessation benefit. So we know that it can help with that. We also know that many clients using crystal are self-treating, untreated or undiagnosed ADHD. And this medication tends to give more of an energetic side effect. They get a little bit of energy boost from it, which they find beneficial in trying to keep away from crystal meth. So all good options, honestly. We have cannabis. I don't see too many questions popping up, so maybe I'll finish up with cannabis and then we'll jump into questions. But if you have questions, let's throw them in the chat. Cannabis will be our last topic today, I think. So overall, WMS clinicians should not assume that a patient's cannabis is safe or therapeutic just because it was prescribed, unfortunately. Regular use of THC is associated with cannabis use disorder, with anxiety, with mood disorders, with psychosis, and with poor psychosocial functioning. So all things you want to be aware of and assessing for. Patients with cannabis use disorder may be offered medications to help relieve their withdrawal symptoms. The medications may be discontinued before they are discharged, or you can continue them for maintenance therapy ongoing if you can find a prescriber to keep that going afterwards. The client shouldn't be permitted to smoke cannabis while they're on site, but that doesn't mean that appropriate use of cannabis prescriptions can't be continued in different routes while they're on site. Although that is limited, there's not many approved reasons for cannabis still. So we do have in the manual a document on cannabis use and treatment, how to assess for withdrawal, what the typical withdrawal would look like, and some treatment options. There's a number of different treatment options that are out there. We chose nabilone and gabapentin for the manual only because they have more evidence for benefit and effect, with a least number of side effects. There are medications out there that have more side effect potential. Not to say that you can't use those either. So nabilone or gabapentin would be a good option for a patient that's coming in and they are suffering from withdrawal from cannabis, or they're at risk for it. Gabapentin obviously has that additional benefit for a client that might be going through alcohol withdrawal, or they're needing anti-craving medication for alcohol use disorder. You can use gabapentin to kind of double hit that client, which is lovely, and they prefer that benefit instead of being on 2 medications. Cool, I made it to the end. So future goals. 1, to continue to increase the capacity of the healthcare capacity in withdrawal managements. 1 nurse practitioner for an entire city of withdrawal is not appropriate or sufficient. Every withdrawal management needs to have 24/7 access to medical care. Physicians, nurse practitioners, nurses, RPNs, they need to be available for monitoring. Not being able to offer best care to our clients because we don't have appropriate healthcare support just isn't a good enough answer at this day and age, unfortunately. So we really need to get there. Great that we have more funding, but we need even more. Standardized withdrawal management care, it's really scattered still across the province of where you're going to go and what you're going to get, whether it's still going to be a bed or a bucket, hopefully not anymore, and what treatment options you're going to be offered while you're in the facility. We need everyone to be on the same page, offering the same care. Better integration into the withdrawal management and addiction care pathway. And that's really going to come with information sharing. If you are starting in a withdrawal management and you're a healthcare provider, introduce yourself to the city, let them know that you are there so that consult notes can flow back and forth from the emergency department to the withdrawal, from the withdrawal to the RAM clinic or the outpatient addictions clinic, and so on. That's the only way that we're really going to provide true wraparound services for these clients when the system is divided up the way that it is. So it's really aspirational, these recommendations in the manual at this point, but we do hope that we're going to get there and that we'll be able to provide this kind of care everywhere soon. Great. Thank you so much.
Thank you so much, Katie. You really packed a lot in that entire presentation. There's a question in terms of the logistics of staffing at the withdrawal management centers. Natasha asked about the logistics. What happens when the one NP that's working at the withdrawal management service, she's sick or on vacation? So in terms of coverage, like I'm also very curious to hear how that works.
It doesn't, which is the sad answer. And this is where it's fantastic. It's a great question, Natasha. Thank you. But it's fantastic that funding was provided so that withdrawal managements now have access to at least one NP or RN and RPN. But it's also kind of a joke on the other hand, because that's not enough. You've pointed out the obvious of, when sick days happen or someone needs a break and they have to take vacation or a holiday or anything like that comes up. One person is just not enough coverage for an entire withdrawal management. There needs to be more. And this is where the funding just isn't there yet. It's almost hanging the NPs and the RNs out to dry when you say that you're going to go in and save this entire system because now there's healthcare providers available. That's fantastic. But it's going to make us look bad when we can't do it with the funding that's there right now. We do need more. So I think we just all have to start advocating and letting them know that this isn't appropriate. We're happy to do the work, but we do need more support still. I had some questions at the end too, poll questions, just about if you, there's the idea being tossed around about doing a withdrawal management workshop, which probably would look like just tons of cases like today, but even more, and complicated situations that pop up and unique situations that pop up. So if you would be interested or think it would be of benefit to have a workshop specifically for withdrawal management. We won't do a poll or anything, but you can put your answers in the chat if you want to.
Jared asked, do you have any recommendations for working with addiction workers who are non-registered in terms of what they can do for assessments?
Yeah, that's a great question. So I think you have to work with your staff and what you have available. So there's all kinds of examples of how this can go fantastic. Owen Sound, for example, they seem to have a ridiculously supportive management team and their support staff. That's meant that even though they don't have specific training coming into the job, they've been provided with education and training on site, for instance, how to do a CWA, so that everyone is on the same page and doing them consistently, which is probably even more important than accurately. You do want the CWA scores to be consistent between everyone that's doing them and every time that they do them, so that those staff are doing CWA, reporting it to the healthcare providers when they're flagging it for concern. And that really means that even more best practice can be done. So things like symptom-triggered treatments for alcohol withdrawal would be available to those clients when otherwise they might not be available. So that's an instance of it going really, really well, where management, all of the staff, all of the healthcare workers were on the same page of making that happen. If that's not the case, where your staff are more concerned about going forward with it, your management aren't maybe supportive just yet, I think you have to work with what you have to start, which might mean starting with things like fixed dosing, adding lots of safety precautions to your prescriptions up front. Like I'd said, things like hold the dose if the client's drowsy. I think that's something that drowsy is a word that everyone recognizes in a client when they present, hopefully. So adding as much precaution and safety as you can and working with what you have, which usually means fixed dosing, more caution, and sometimes more emergency department transfers, and just building up slowly over time until you have that trust where you could provide that education and training to the staff, or have the funding to get RPNs and RNs on board as well.
I do hope that in future that happens. Yeah, more funding would be nice.
Agreed.
Awesome. Thank you so much again, Katie.
Thanks for having me. Thanks, everyone.
Presentation, and
Enjoy the rest of the conference.
Thanks.